you. I'm up to.
Okay. Hi, Natasha.
Hi, Dr. Carr. How lovely to meet you on Zoom for this wonderful Women and Heart Disease event. I know
Yeah.
it's your baby, it's your area of absolute passion.
As is yours. So, Natasha, you do you realize how many different medical hats you wear? So, you're a functional medicine doctor, you're an aesthetic medicine specialist, and you are an emergency room doctor as well.
Well, my original training was in ER, yes, and that's what I did for many years. And then that's what led me to functional medicine because I was so fed up with seeing people being sick and at a point where their lives are never going to be the same again. They're now riddled with the disease burden and disability. And functional medicine was the way out, where you can keep people healthy, restore their vitality, give them back their lives so they don't end up there. So
Yeah.
that's when I made the transition and got into functional medicine. But yes, through COVID, I went back to assist in the ER. So I do some shifts there and I see lots of things that make my heart hurt. On heart day, my heart hurts.
I know you come back and tell me some of those stories, and sometimes it's like, oh my God. So, okay, Natasha, not everybody knows us. So first I'll let you introduce yourself, and then I'll introduce myself. We sometimes forget. We just assume, our people know us.
And our people do know us. That's why they follow us all the time. And I'm so grateful to all of our regular followers who sign up for all of our events and listen to us and love the education we provide. So to all of you, thank you. And to those of you who are new to us, I'm Dr. Natasha Iyer. And my passion is helping women, especially, I treat men as well, to restore their vitality and live longer, healthier lives through functional and longevity medicine. Yes, I have a keen interest in skin health because my primary area is bioidentical hormone rebalancing, which I think is essential for healthy aging and longevity. And hormones help your skin stay younger as well. So that's how it all ties together. And then there's a certain thrill of being in an emergency department and doing all things that make most people's eyes fall out. Or, my children call me they said that people would think I was a psychopath if they looked at my phone with all the gory pictures that I have and things like that. So I do that a little bit now to be of service. But my primary passion, absolutely like yours, lies in functional medicine, which is putting bodies back to their optimal and best function.
Yeah, it's actually so much more exciting to practice medicine today. So I am Dr. Shabnam Das Kar. I am a functional medicine doctor and a brain health coach. And both of us, Natasha and I, are in Alberta in Canada. Because Natasha, a whole bunch of my friends are joining in and they sometimes they won't know where we are. And by background, I'm an OBGY. So when I got to know about, the uniqueness of women and heart disease, women and stroke, first of all, I thought, how come I am so ignorant? You know,
Yes, because you only learned about below the belt stuff.
but the below the belt stuff, Natasha, is connected to the stuff that goes way above the belt, the
But
heart and the
that's why
brain.
it's different in functional medicine. Traditional medicine, we're so compartmentalized that we don't see the whole picture. Whereas now, you and I both, we look at the entire picture of the person and everything that makes them who they are, including their childhood and birth history, right? So sorry, carry on.
So this is where, in when since we started practicing functional medicine, or I started practicing functional medicine, so a large part of what we do is help people change their lifestyles. Now, I'm trained as a tiny habits coach as well. And Dr. Iyer and I are excited when patients come back and tell us, you asked me to do this, blah, 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 blah. Like yesterday, a patient was telling me she had I call it a relatively simple problem like iron deficiency. Now, that was making her, she said, I can't exercise. I don't feel I have enough energy. I said, oh, we need to check. It could be iron, it could be a whole bunch of nutrients, and you're not on your supplements now. You were feeling much better when you were on them. And sure and certain, she found out she was iron, deficient in iron, and she said, thank you so much. I said, it's not just me. I can just tell you what to do. You are the one who's doing the hard work. So anyway,
Yes.
before we digress too much, I think
But you didn't tell us about your interest in why you do this cardiometabolic, and you said you're a brain health specialist. And so, um, the whole connection between the heart and brain, your lovely logo. So just take another half a minute to tell us about why you moved into that direction, or
so
what is it
I
about it?
changed my focus into specifically brain health. And most importantly, in prevention of dementia, getting rid of brain fog, improving focus based on, a whole lot of lifestyle changes and prescription medications and supplementation. Everything works together. And I realize that not a lot of people are focused on prevention of dementia, in the sense that we know that there are no curative treatments for conditions like Alzheimer's. Alzheimer's is the commonest type of dementia. But the fact that the brain and the heart and the ovaries and everything else is connected to everything else, that is a perspective that we bring from the world of functional medicine, because I was used to just looking out for the tubes, ovaries, vagina, vulva, that part of it, delivering babies, doing surgeries. And I forgot that the heart and the brain and the gut and everything else has so much of an impact on everything. So, first of all, it's like there is a lot we can do to prevent heart disease. And Natasha, you were telling me about that, the story in the ER I think it was just a week ago or so. And women and heart disease and stroke, the story, even in a country like Canada, it's a first world country. So, things are much better here. More women are dying of heart disease today than before. And the trend has been rising since 2015. So, Natasha, will you share with us one of those stories that you were telling me about? And it was so painful to, know that.
Mhm. So one of the things we're seeing is younger and younger people coming into the emergency department with heart attacks. And just you mentioned brain and heart. I think for all of you listening, what we need to clarify is that heart disease and brain disease are very closely connected. And if you've got cardiovascular disease, which is a disease of the blood vessels around your heart that's going to give you a heart attack, you are having the same kinds of changes in your brain, and you may get a stroke before you get a heart attack. In fact, I just saw a 48-year-old who had had a stroke. 48-year-old woman had a stroke. Now, when it happens that young, there's other things going on, which is why
Yeah.
I'm so excited that in one of our slides, we're going to talk about some of the 400 and some risk factors that exist for heart disease. And yet people think it's just cholesterol. People obsess about their cholesterol levels, and they think that's all there is to do with heart disease. So today we're going to be sharing with you how much more there is to know about heart disease risk beyond cholesterol, beyond blood pressure, and that sort of thing. So I had a 42-year-old woman come in having her third heart attack within 3 weeks. So she
Oh,
had
my.
two, was in the coronary care unit, got discharged, and came back and had a third heart attack. With her was her daughter and a like 6, 8 month old baby. Can
Oh,
you
yeah.
imagine being a grandmother and knowing, like, I know her life is never going to be the same again, right? Because
Yeah.
she's had her third heart attack. It's damaged the heart wall and ability to pump. She's going to be on medication. She's going to have the side effects of the medications. She's going to be tired. She most likely will end up with depression after. Now,
Hmm.
let's not even talk about someone who's having their third heart attack. Let's talk about people who have even their first heart attack. A 36-year-old male, and I know this is women and heart disease, and we know men get heart attacks, and we somehow forget that women get heart attacks. It's just
Yeah.
not a thing. It's never top of mind for people that women get heart attacks too. It's always men that we talk about. But I will mention that I treated a 36-year-old man for a massive heart attack. And this was not even like 6 months ago. So it is happening sooner and sooner. And what's more frightening is that people think it just happens, right? But
Yeah.
we know it starts in your teens and your 20s. So for all of you listening who think it's not going to happen to you, that's fine. You can hopefully learn from us that it could very well happen to you no matter how fit and healthy you are. But think about your children. Think about your teenagers. Think about your 20-some-year-olds. What they do today is determining what's happening in their future. And that is also why we're seeing so much more heart disease. Because you were talking to us about for Dr. Kar and I. Dr. Kar is our director of medical education for the clinic. And she reads all the literature, keeps up to date with the latest and the best science that's happening. And we adjust our clinic protocols and approaches. We discuss patients every week and we see how we can implement this. But you were talking about toxins and heart disease, right? Who talks about toxins and heart disease ever? Never mind that we don't talk about women and heart disease, but who talks about toxins and heart disease? Yet we're living in a toxic soup. All day long, we're exposed to toxins. So our children are having way more exposures and way higher risks of the very things that we're going to talk about, and they're getting heart attacks sooner, right? So, yes, I'm seeing people who are younger and younger. I want to talk about the lady I saw last week that you were, so surprised about. So this was a 68-year-old who came in with right shoulder pain. And she said to the nurse it was her jaw. So, of course, we thought cardiac, even though it wasn't the shoulder that you would normally think of. But when I spoke to her, she said, it's actually my gums. I have dentures, and it's just, I've never heard this from anyone before, ever. I've been doing emergency medicine and practicing medicine for 27 years. This is like, I've seen a lot of different things. I've never heard someone say, it's my gums. And if I took my dentures out, that's when I know it's inside my gums where my teeth should have been. And and I thought, oh, that's odd. And I touched her shoulder, and it hurt. Now, I always tell patients you can't make heart pain hurt. So if I touch their chest wall and they jump, that's not a heart attack. That's a costochondritis or chest wall muscle, something or the other, but it's not a heart attack. So this woman had me floored, but I still ran a cardiac set because she's diabetic, and we have that in a slide for you. The diabetes is a significant risk factor for heart disease, regardless of how good your cholesterol is, right? And so I ran her heart enzymes. Her ECG is normal. So the electrocardiogram that tells us, you can see changes, and that's how you know there's a heart attack. Her ECG was normal. I still ran the cardiac set because she's diabetic. And there's a thing called troponin that tells us if there's heart muscle damage. It was slightly elevated. Now, you can get a slight elevation in other things that are happening. So we don't always act on one thing. Because when I saw her, she no longer had pain. She had a normal ECG and a slightly high troponin. And as I walked away, she yelped again and she clutched her shoulder. So I went to her and I said, okay, let's just do another ECG. And there it was, huge heart attack. So of course she was in the right place at the right time. We got it done. We talk about a door to needle time of 30 minutes. We got it treated very quickly. She got everything, and she went off to the coronary care unit in Calgary. And so that was the most atypical presentation I could give you, because I know today we wanted to talk to women and men about how you present for a heart attack that may not even sound like a heart attack. And I couldn't give you a better story than that.
So
Right
this is,
shoulder pain instead of left. Gump, it was just
yeah.
weird. But you and I were talking about all of the symptoms, and I said we don't want to confuse everybody and give them too many things. And you said sometimes you can get sleep disturbances, and I said I don't want to talk about that, because all women who are hormonally challenged don't sleep. All people who are stressed out don't sleep well. All people who drink wine before bedtime don't sleep well. So, I didn't want to leave sleep disturbances, but you can get that as a hint that something else is going on. So you talked about dizziness and lightheadedness. Yes, sometimes that can be the only symptom, but typically there's other weird symptoms that we're going to cover. But I think today, if you get anything out of this, it's when should you worry and what should you do about it? And then what I urge you to do mostly is, if you go to an emergency department and you get dismissed as something else and you think it's your heart, absolutely advocate for yourself. Do not leave without that ECG and the heart enzyme test, because what did you say, 50% of women
50% have been misdiagnosed or
misdiagnosed? And I'll tell you, 25 years ago, I'll never forget this. I moved to High Prairie, Alberta 25 years ago. Her name is Shirley. Can't identify her by more than that, but let's talk about Shirley. Shirley was in the emergency department 3 times with heartburn and burping.
okay.
So she was given what we call a pink lady to settle the heartburn. She was given a proton pump inhibitor, which lowers stomach acid, and sent away. Shirley was probably, I think she was 52 at the time, right? Which is
Mhm.
my age.
Mhm.
She came in on my shift for the 4th time, and she was still uncomfortable in her lower chest area. And she said, I'm back for the heartburn. The medicines aren't working. And back then, we didn't ever look at people and say digestive disturbance can indicate a heart attack in
Mhm.
women, right? Because it's not common in men. Women will usually
Yeah.
show up with this type of thing. And I ran her troponins and they were high, ran her ECG and there were changes, but this was already day 4. We couldn't do the clot
Mhm.
bust, not that we had the same kind of clot busting drugs
Yeah.
25 years ago. It was a different situation then. But Shirley was never the same again. She never went back to living her life normally. Not because she wasn't treated, but post heart attack, we have serotonin receptors in the heart, which we know today,
Mhm.
right? Back then, we didn't know about this, but we knew that people got depressed after a heart attack and then they end up on an antidepressant. And all the drugs you take for a heart attack make you tired. They
Mhm.
make you sleepy. They make you have muscle aches and pains or whatever. But she was depressed and she never went back to her career. She never lived the life that she was used to living. And that's the problem, that, we don't take heart disease as seriously. I don't know why. Like, a lot of people go, oh, no, I'm not worried about my heart.
Mm.
What do you mean? And everybody that comes to see us for hormones, because that's what they come for, and they're like, oh yeah, I didn't get my mammogram this year. Your chances of dying of a heart attack are far higher than from breast cancer. So let's get
Yeah.
to teaching or educating our audience on all of these things that you made such lovely slides for.
Thank you, Natasha. So I'm just going to give an overview of what we are going to talk about today. First, Dr. Iyer mentioned about, so we'll talk about the symptoms of heart disease. And one of the biggest problems is women tend to ignore their symptoms. Now, you were talking about patients who reached the hospital. That's very good that they didn't stay at home thinking, oh, it's just a heartburn, I'll get over it. One of the things is women ignore their symptoms. And the other thing that really got me concerned was most women do not know their risks. And there are a whole lot of risks that are unique to reproduction. That is where, Natasha, I got the shock of my life as an OBGYN. I didn't know all that back then. So I'm going to start sharing a slide, and not a slide, a few slides. Okay, where is the... Okay, so this is, and of course, we're going to talk about hormone therapy and steps to reduce your risk. So this is kind of a long list of risks that you probably don't know about. And recently I was reading a book written by a lady in Calgary. Now I forget the name of the book. She was in her, I think, 50s, and her father had heart disease, and she, like with chest pain, she went to the doctor. And women and heart disease are a lot of different things. We won't have time to go into all of that. But she thought she had no risks for heart disease, but she had pregnancy diabetes and she had pregnancy hypertension, so preeclampsia. So Dr. Iyer and I know when people say I don't have any risks, we know we will find at least 3 risks for sure.
So that's the biggest thing. If you have a heart, you have
Yeah.
risk. If you have stress, you have risk. If you live on this planet right now filled with toxins, you have risk. And like in our intake forms, we actually ask about the weight of babies because many people don't know that they have. Now we're good with screening, but
Yeah.
20 years ago, we were not good with screening for diabetes in pregnancy. 30, let's talk about 30 years ago. It wasn't as detailed as we are now. And so
Mhm.
we see a lot of women who didn't know they had gestational diabetes, yet they had a 10-pound baby. So 10
Mhm.
pounds, close to 10 pounds, over 10 pounds, you probably had gestational diabetes.
Yeah, that's very important because and some ethnic groups like South Asians, indigenous people, I think other than non-European ancestry, women are at a much higher risk for pregnancy, diabetes. And this is where, again, probably many of you will have to advocate for yourself because South Asians, particularly I know because I am from India, need to be screened for pregnancy diabetes at the very first visit, not in the second trimester. So that's just something you need to advocate for yourself because not all doctors are aware that those who are high risk need to be seen earlier. And today I read something which was again not unexpected. We know that so women who have pregnancy diabetes or preeclampsia or pregnancy hypertension, their children are also at a higher risk for heart disease down the line when they are adults. Now, as you can see, this list is long and you will receive this is a very long questionnaire. I think I'll just share briefly the questionnaire that I'm talking about. You will receive a copy of that. And this is basically for you to know your risk. So Dr. Iyer and I are majorly concerned when people say, I didn't know my risk. So here I'm just scrolling through this. So this is again, Natasha, you brought up alcohol. The safest amount of alcohol is 0. We know it, but we still love red wine. So all this long list, I'm not going to go over these now because then we'll be here until forever. You can go through them. See, something like, cancer chemotherapy, a lot of people are not aware that radiation to the chest increases your risk for heart disease. Nowadays, many centers have cardiologists in the oncology division. So a lot of these things, and we address all of them, Natasha, in our practice. So
Well,
this is
you make
just
sure of it. So,
that's why I have a checklist because it is humanly impossible to remember that long list. And we have a similar checklist for brain health as well. So I will go back to my PowerPoint. Where is that? Yeah. Okay. So this we've already talked about. And Natasha, maybe we'll just keep that slide for a few seconds on the screen so that, if any of you want to take a screenshot, please go ahead and do that. Most importantly, remember that any symptom out of the ordinary, like shortness of breath, extreme sweating, even if it's a very hot day, Dr. Iyer and I would, really, really stress on this that you should not neglect any of these. And very
that's right,
often,
because like you said, people show up days later. It's women mostly. And the
yeah,
reason is because we always think heart disease is a man's disease. Look at all the things they do. Look where they're, oh God, don't even talk to me about where their stamps for heart and stroke are on margarine and box cereal as heart friendly. Don't fall for any of that. So I think we left out talking about diet and the myths about diet as and somewhere along the line we have to talk about the simple fact that the diet that's recommended today as healthy is the exact opposite, right? You should never use margarine. Butter is better. You should not avoid red meat. There's nothing wrong with saturated fat, provided it's done in a proper way within a diet. But we promote a natural whole food diet. Ultra processed foods all over the news in the last multiple months, right? Avoid processed food. rich in vegetables, antioxidants, polyphenols, all of those things. You've heard this before, but it's a substantial amount of protein, vegetables, and low carbohydrates, because we know that carbohydrate consumption influences your cholesterol profile. And
Yeah.
I did say something else that we don't have a slide on, and we weren't actually thinking about mentioning it, but cholesterol levels really, I know that the standard right now is ASCVD, so atherosclerotic cardiovascular disease, and your LDL number. Everybody's talking about how you can't have a high LDL, it's going to kill you, all of that. But I will tell you, in my practice, we have, how many 80-year-olds we have who are
Yeah.
doing really, really well. They've all been healthy since way, way, way before, and they've come to us for longevity and healthy aging, right? And the hormone balancing. However, I have many of them refusing to take statin pills, the cholesterol lowering medication, for high cholesterol. But here they are in their 80s with high cholesterol that's never been medicated, and they don't get a heart attack. The one important statistic I will tell you is that more than 50% of people who have heart attacks have normal cholesterol levels. They've been checked, everything's been looked at, and their cholesterol is normal. So this is why I was picking on cholesterol at the start and saying everybody thinks it's cholesterol when there's so many other things you need to know about. And no, I eat eggs. I eat meat every single day. I eat about 8 or 12 eggs a week. And my total cholesterol is 4.22 and my LDL is 1 point something. So if saturated fat, steaks, eating the skin off the chicken and the fat off the steak, and having butter every day and coconut oil, if a high fat diet was a problem, why is my cholesterol normal?
Mm-hmm.
So it's beyond cholesterol is what I'm saying.
Yeah, cholesterol is just one of the risk factors, and in women, actually, a high triglycerides is a much bigger risk factor. And as we know, triglycerides, the best way to take care of a high triglyceride level is number one, through low carbohydrate food, and
Lower your
number two is
carbs.
omega-3 fatty acids. So, and women and statin, Natasha, maybe that's a different conversation for another day.
Give us that 30-second thing.
Yeah, there is no data to support statins for women as a primary prevention, meaning for a woman who hasn't had a heart attack or stroke or any of this. So there is no data to support that. And we are still recommending that. And doctors still focus on that LDL.
Yeah, and one thing I want you to quote is that study that showed the 4-day.
Yeah, the benefits of using so statin is a cholesterol lowering medication, atorvastatin, rosuvastatin, the whole lot of them. Studies have shown that they increase your lifespan by just 4 days. And I had a cardiologist telling me, I don't believe it. I said, this is not a cult. This is data.
It's scientific data.
Yeah.
We didn't make it up. So,
No.
we're throwing statins at people, but we're not looking at these 400 risk factors that people have that elevate their risk for heart disease. And then we go send them for a stress test. A stress test is only positive when you have like 80, 90% blockage in your heart vessel, which is why in our functional medicine practice, we do coronary calcium scores and we recommend other testing to
Mhm.
see if you are starting to have thickening of the vessels, stiffening of the vessels, blocking of the vessels before it causes a problem and before you get the angina and the chest pain and then a positive stress test. A negative stress test means nothing. The only time it means something is, yes, if it's positive, because then you actually have so much disease burden in the heart that your risk is very, very high. But a negative stress test means nothing because you could leave that doctor's office, go to your car, and have a heart attack
Yep.
in your car, having had a perfectly clean bill of health. And then there's one other thing I wanted to mention. I know that, okay.
Yes, Natasha, I was
But I
going to
did want to
interrupt you
mention
very soon.
exercise because we have so many people saying, I do spin class, I do yoga, and then how many of our patients, and I don't know what it is about women, but either for their 40th or 50th birthdays, they want to run a marathon and they love running and all of that. And I wanted you to mention the risk of heart disease in people who are high athletic, which you would think are the healthiest people you can get. And so I want you to comment on that and that Boston heart study, the Boston Marathon
Yeah.
runners heart
So,
study.
Natasha, you brought up something very important. So, extreme exercise. So, this was the study that Dr. Iyer is talking about. Is they did a study on Boston marathon runners. Now, marathon running is like this is I think 42 kilometers is the full marathon. What they found is many of them had raised heart enzyme levels, the troponin that Natasha mentioned earlier. So this is not for Dr. Iyer and I to tell you that you should stop exercising, but at the same time, don't ignore your risks. Let us say you're someone who had pregnancy diabetes, who had pregnancy hypertension, and you're going in training for a marathon. You need to know what you need to be aware of, and you don't know your blood pressure. Like, I'll keep on hopping on blood pressure, but Natasha, in the interest of time, I want you to talk about hormones and the misinformation that women are given about hormones are going to kill them of heart disease and cancer
What
and
I'm going
stroke.
to
I
ask
don't
you to
know.
do before we talk about hormones, can you please put up the slide? And we're going to do this a little backward. I don't know why I didn't think about it before, but can
Which
you put
slide?
that slide up on the benefits of hormones and heart on the
Oh,
heart?
I am sorry, Natasha. I don't think I have that added. Was it
I
not
think
before?
I got it in there. It's just
Ah, yeah, this
here,
one.
that one. So let's talk about this first because it's related to the heart, and then I'll tell you about my view on hormones.
Hmm. So,
I don't know too many people who know that optimal levels of estrogen improve your cholesterol
mhm.
levels. So, yes, we said cholesterol is not everything, but it has something to do with it because there's cholesterol in the plaque of your blood vessels. So, with us in functional medicine, we're looking at the global picture of all the aspects of you and who you are, your physiology, your biology, and everything. And we put it all together. So imagine knowing that as you get to the menopause, your risk for heart disease actually increases. As your hormone levels drop, you're getting overweight, your blood pressure is rising, your belly fat's increasing, and your cholesterol's changing. And when you replace estrogen, these things improve. The other thing is, we already know that menopausal women are at risk for low bone density. And what happens when you're losing bone density is you're releasing the calcium and minerals and things from your bone as it's tearing down. And what we know is that this calcium that's now available in your body is more freely available to plug up your arteries as you're losing bone. So if you have inflammation, which we're going to talk to you about, and if you have a whole bunch of other things, simply being in the menopause and losing bone could increase your risk and formation of heart disease. And in 2021, there was a paper written on menopause and hypertension and how blood pressure changed higher as women lost hormones and got into the menopause.
Yeah.
So there are definite cardiovascular benefits to replacing hormones besides all the other benefits that we know. And I just listed 3 here. Dr. Kar, you have multiple other benefits of hormones, and why we should replace them because the data is clear that replacing hormones matters to healthy aging. For me,
Yeah.
when I opened the clinic in 2006, my most famous statement was, and actually I say this all the time, you
Yeah.
age because your hormone levels decline. Your hormone levels do not decline because you're aging, contrary to what medicine says. Because when you were checking women in their 60s and they had a less than 30 estrogen, you said, oh, that's normal for you. You're 60. It's
Hmm.
normal to not have estrogen. But it's not normal to have your brain going and your thinking going and brain fog and you can't find words and you're going to get a dementia from not having hormones. So I said that so many years ago, despite the WHI, which caused this major ruckus in medicine and in the media, and everybody is talking about how everyone has to get off hormones because they increase your risk for cancer. And we know that that is not accurate at all now that we've had a chance to look at that data many, many, many times over for 20 years, right? So You age because your hormone levels decline. So when we want vitality, when we want healthy aging with a fit brain, a fit heart, muscle strength, low blood pressure, everything being healthy, we must rebalance hormones when they start declining. You always talk about the timing hypothesis, which many women have missed. And I say, even if you missed starting
Mm.
hormones as early as you can, like in the perimenopause is when we should be starting hormone replacement therapy and balancing it so that we skip the menopause and we just transition smoothly without any of the negative impacts to long-term health and short-term health, like crankiness and not sleeping and all of that, right? So hormones are essential for longevity and healthy aging. They need to be balanced safely. You need to be monitored carefully. And we look at those things when we're balancing hormones for our patients. So, in my mind, every woman should be on hormones. And today we cannot talk about the women who've had estrogen dependent breast cancer and all of the other questions that will come up. But I will also say this is in the literature, it's in the scientific literature. So it means that if you're a physician looking after women and people with heart disease, you should be aware of these studies, even the studies on toxins and heart disease and whatever. And I have a patient who, unfortunately, we predicted for her, if you remember this, Shabnam, we said she's at high risk for heart disease because she had high triglycerides, she had an autoimmune disease,
Mm-hmm.
and she had high insulin, right? So she had
Yeah.
hyperinsulinemia, but she was a skinny, healthy woman who exercised, looked great for her age,
And
whatever.
Natasha, she had a very high sitting risk, sitting
Score.
disease score. Yeah, where she used to sit for about 8 or 9 hours at work continuously.
Okay, so when she had her heart attack and got shipped off for a stent, she
Hmm.
said, I'm on hormones, and her cardiologist flipped and made her stop everything. But he didn't even ask
What
what
type of
type
hormone?
of hormone. So we know now through the North American Menopause Society statement, position statement, right? So it's the NAMS position statement. It says very clearly that transdermal estrogen does not increase your risk for heart disease. And it's not inflammatory and it doesn't increase blood clots. We know this,
Yeah.
but he didn't ask. And
No.
here's the kicker, she wasn't on estrogen. She
Yeah.
was on DHEA and
I know.
testosterone, and he didn't even know the difference.
Yeah.
And testosterone helps you with blood sugar control. It helps you with muscle mass. It helps you with mental agility. It helps you with bone strength and
Libido.
preventing loss of bone density, right?
Mm.
So these are the things that go on. And that's why you, as a patient, need to advocate for yourself. You need to be interested in enhancing your knowledge so you can ask for this sort of thing. Not everyone works with us. I mean, I think everyone should. I
Hmm.
think everyone should go through our program and our process and learn how to eat and identify their risks and prevent dementia and cancer and have younger looking skin and not have high cholesterol, heart disease, and bone density loss, right? So I think everyone should, but not everybody will because, for whatever reasons. I mean, we consult remotely. We have patients outside of Canada, many, many places, right? My
Yeah.
furthest one is in Peru. So, and I've got patients in Saudi Arabia even. So, like we do consult all over the world, but I urge you, if you're not going to do a program like this where we look at all your risks and hormone balancing, at least understand it so you can have a good conversation with your own physician.
Yeah, that is very important. So I'm just summarizing, Natasha, what you said about hormones. You mentioned the window. So that is what is called the timing hypothesis. So what studies have shown that hormone therapy and the right hormone therapy, I'll talk about what the right hormone therapy is that Dr. Iyer has been talking about. Hormone therapy started within first 5 to 6 years of menopause has more benefits than hormone therapy started later. But that does not mean that if you have missed that window, hormones have no role in your life. That is not true. So the standard recommendation now, this is the North American Menopause Society's guidelines, which is supported by all the other multiple societies all over the world, is women can be safely on hormones as long as they're monitored well, even into their older age. And the other important thing is the type of hormone therapy. So estrogens applied on the skin as creams and or patches, depending on where in the world you are, what is
Gels.
available. And oral micronized progesterone, that is bioidentical to what our bodies make, is very different from the hormones that were tried in the world WHI study, Women's Health Initiative, and we are still facing the repercussions of that study. An entire generation of medical graduates have ended up learning poor information and incorrect information. That was a different hormone therapy, that was oral estrogens micronized. It was not oral micronized progesterone, it was something else called a progestin, which is very different from what our bodies make.
A
So in
synthetic
the
form.
interest of time, Natasha, I'm going to go ahead with the next slide because I don't want to go over a time limit. So again, there are too many things here that we would love to keep talking and talking and talking about. So Natasha, will you say something about the lipid particle analysis? Because, and again, feel free to take a screenshot if you want to our audience. And if you have any questions, of course, you can reach out to us. Our email IDs will be there you'll receive a recording of this. So Natasha, what is the lipid particle analysis?
Before I do that, I just want to quickly run through these things. So know your risks, you're going to get the form. Monitor your blood pressure. It is not true that above 140/90 is only when you should pay attention.
Women need a lower threshold.
Not only that, but I think everybody should have far lower blood pressure. In fact, my diabetics have a target of 110/70. I don't tolerate anything higher because we already know that you have a higher risk of heart disease by having
And
diabetes.
again, just an aside, this does not mean that you are on 25 medications because we use a different approach. It's a medication combined with lifestyle change because we know how to help you make lifestyle changes.
That's right.
Go
And,
ahead.
and even this morning, my Facebook Live video, I was saying, I fell off track for 2 weeks. I wasn't on the bike and all of that. And so when you say tiny habits coaching, that's what you're trained in, and that's the value you bring to our patients because it's very hard to make lifestyle changes that stick. It's the first thing that goes when you're stressed or busy. Insulin resistance is a very simple thing to diagnose, but no one does it. It's a routine part of functional medicine. It's detecting your risk for pre-diabetes. We don't wait until you get
Yeah.
pre-diabetes to diabetes. We're going to tell you 10 years before it's coming. Fatty liver, a lot of people think eating fat causes fatty liver. No. Insulin resistance and carbohydrate consumption cause fatty liver.
Yeah.
What people don't know, even though a lot more people are talking about fatty liver, what people don't know is that fatty liver raises your risk for heart attacks,
Yeah.
strokes, diabetes in a way that nobody pays attention, but it is magnitudes of importance.
Yeah,
So,
people with fatty liver die of heart disease, stroke. They don't necessarily die of liver cirrhosis or liver cancer.
and
Yes,
they
the risk
can,
is
and
there.
fatty liver can progress, and you don't need to
Yeah.
be an alcoholic to have fatty liver.
No,
Right
no.
now, it's one of the biggest reasons for liver transplants in North America,
Yeah.
having fatty liver. But what's the point of getting another new liver when your risk for heart disease is up because your underlying issues have not been corrected? Inflammation drives everything, and inflammation is caused by diet and toxins and lifestyle and lack of sleep, and the list goes on, dental things. But if you have inflammation, we need to lower your inflammatory markers down to rock bottom, or else your risk is high. It doesn't matter if your cholesterol is normal. It doesn't matter if you can run a marathon or stand on your head, for goodness sake. It doesn't matter how healthy you think you are if you have any of these things we're talking to you about. But inflammation is one of the most important things you have to settle. Part of your longevity assessment with us, we look at the waist circumference, waist to hip ratio. Dr.Kar loves talking about sitting time. Sitting disease is worse than smoking to your health. So taking movement micro breaks, setting your alarm, moving, not sitting for 7, 8, 9 hours at a time. Then building stress resilience. Stress kills. End of story. Stress kills. You could be the healthiest, leanest, most active person and you have stress that you haven't figured out how to deal with, and your mindset is stuck in stress and it's overwhelming and you're living in stress, you're going to be sick and you're going to have a heart attack most likely. So lipid particle analysis and advanced cardiac markers or heart disease markers, these are, some are routine, some are available on routine blood testing. And so we do those things like your apolipoprotein little a, your apolipoprotein B. These tell us if your genetic risk and if your cholesterol that you have can become dangerous to you. So we said that a lot of people who have heart attacks have normal cholesterol, more than 50% of them. So how do you explain that? It means that they can oxidize their LDL and create plaque. You need inflammation. You need a weak immune system to make plaque. So immune system is very important, and we look at the immune system of everyone. We should have added it here, but again, 50,000 things to tell patients. So looking at your apolipoprotein B, we can tell you if you are prone to making heart disease more likely, even if your cholesterol's normal, right? And then we can actually help you change these levels back to normal through diet and lifestyle. Some supplements if necessary. Looking at your omega-3 index, that's the cell membrane quantity of omega-3. And then lipid particle analysis is a rather inexpensive private test out of the United States. We don't have access to that here in Canada. But what is really important is knowing your particle size and number more than what your cholesterol numbers are. And again, I'll take you back to the fact that more than 50% of people who have heart attacks have normal cholesterol. And so
Another important thing, Natasha, you mentioned it before. 50% of people find out they have, or rather had, heart disease when it's a sudden cardiac death, is what we call it. Death is the first sign of heart disease.
I said that to a patient, and I'll tell you that story in a minute. Lipid particle analysis, why is it so important? If you think about your blood vessels, they have cells that are tightly put together. When cholesterol, and it's complicated, it's not just cholesterol. Like I said, you need inflammation, a weak immune system, you need other cells, and the cholesterol, it gets through the membrane and goes behind and forms a plaque that can push through, and then the plaque forms and there's rupture that happens, and that's when you get the heart attack, right? But if you have small, dense lipid particles, even if your blood cholesterol level is normal, but they're mostly small, dense, tight, heavy cholesterol, they can push through the lining of the blood vessels easier than big fluffy particles. And what we know is that if most of your cholesterol is big and fluffy, you cannot push it through and make the plaque. So your particle size and number matters more than your actual cholesterol level. And so if you want to know, and like I said, if you have a heart and you live in North America, you have risk. You absolutely are.
Oh, you live anywhere
You
in the
and I
world,
both are at
Natasha.
risk, right? Like we're not even outside of the risk factors right now.
Yeah.
Right? So we do what we can to manage our risk, but knowing your lipid particles, I think everyone needs to know that there's such a thing. It's called lipid particle analysis.
Yeah. And anyway, these are.
Okay, so now I didn't want us to, I wanted you to
No.
put this up, but I
Yeah,
didn't
but
want to
we don't
talk
have time
about
to
it
go
in
through this.
detail.
Yeah.
And the reason I said to you, one, it's going to be really confusing for patients, but understand that it's not just about plaque in the vessels. You know, there's the broken heart syndrome, right? So people can have heart disease after severe grief reactions.
Yeah. And happiness too.
Okay, well, I'll try not to get too happy anytime soon. Microvascular disease, this is critical because we know that insulin resistance, diabetes predispose you to microvascular disease. And we also know that the greater majority of people that we work with are insulin resistant and are going to be diabetic in the future. This is another story. I saw a lady in a small town called Bassano years and years ago. I only had one kid at the time, I think, too. And she came in with classic chest pain. Her ECG was normal. Her enzymes were normal, and you need 2 out of 3 to make the diagnosis. I
Mm.
had 1. I had chest pain. And I kept thinking there's something wrong with this woman. And I called, and the specialist wouldn't take her. They wouldn't give her a bed in the coronary unit. And she had family history of heart disease. She had the belly fat and the high waist to hip circumference. Like, you can just tell these things by looking at
Mm.
people, right? She'd had some high cholesterol, but wasn't enough. And then finally, I got a doctor on the phone. I called 3 times. I called 3 different places to get her a bed in the CCU, or at least get a cardiologist to look at her. And I said to him, I said, please have a look at her. I'm not comfortable keeping. I think she has microvascular disease that's causing these symptoms, and some element of coronary vasospasm. I don't know where I came up with this, because I couldn't diagnose this in a small little ER that has no tools, no equipment, no imaging, no nothing. But it was just her story, and how she looked like she was having a heart attack. And I found out later that she did have coronary vasospasm, and she needed treatment, and they did treat her, and she was fine after. So it was just a gut thing, because I know these things exist, and so I don't just assume that you've got 1 out of 3, I'm not diagnosing. And that's what I say to you: advocate for yourself. If you think you're having a heart attack, if you have any concern for your heart at all, no emergency room doctor should say no to you if you ask for heart enzymes and an ECG. And
Yeah,
you need to say, what
absolutely.
if it's coronary vasospasm? What
Yeah.
now? Spontaneous coronary artery dissection, not common, but it exists. And you need to know that these things are not typical heart attack pictures and actual pathology, the underlying disease process of a heart attack. They're different, but they still
Yeah.
affect you the same. And so you need to say, please look at me closer.
Yes, and SCAD is particularly important for younger women and women soon after delivering a baby, because very often women have had this terrible experience of going to the ER with chest pain, with the symptoms, and being dismissed as you are too young.
Yeah.
No one is too young to have a heart attack. No one
Not
is
when
too
I'm
young
seeing
to have
36
dementia.
year olds in the hospital. No,
No.
never
So
too
I
young.
am going to rush through this because
Yep.
this is something very important. So, Natasha, what are the next steps people can look forward to?
If you haven't had one, you should absolutely get one. It's called our Advanced Heart Assessment, and it includes all of these things we've been talking about. Dr. Carr is going to look through your 400 and some. Luckily, you're the academic, and I just like to talk to people. She's going to look at all of your risk factors with you, and we're going to fine tune the number of risk factors, because obviously, the more risk factors you have, the higher your risk is. The advanced cardiac markers, finding and monitoring and solving inflammation. IR is insulin resistance, and we can check it on blood work, and it's also part of your lipid particle analysis. Dr. Kar's brought into our practice a very fascinating wrist device that checks your blood pressure. So here's the thing. A lot of people have high blood pressure, but they don't know about it. It's kind of like the sugars. I saw one yesterday. Blood sugar level was normal. Fasting insulin was through the roof. But anyway, her hemoglobin A1C, which is a 3-month profile of her blood sugars, was high and in the diabetic range. But if you just looked at her single point blood sugar, it was perfect, 5.2. Everyone's going to
Oh,
be, oh, that's great.
yeah.
Everything's fine. Don't worry about it. Then you look deeper and you go, oh my, you must have big jumps in your sugars at different times of the day or night, that your 3-month cumulative profile is now in the diabetic range.
Mm-hmm.
By the same token, your blood pressure can do the same thing. You can check your, and everybody does this. They go, I take it in the morning, I sit down, I have my coffee, and then I take my blood pressure. And what about the rest of the day and the night? And then what about the non-dippers? And what? Okay, so I'll tell you quick. Dr. Carr started this effort in our clinic years ago, where she was insisting that people get a 24-hour blood pressure monitor because of this non-dipping status. There's a group of people that do not drop their blood pressure as they should overnight. And these are the people that wake me up at 2 and 3 o'clock in the morning having their heart attacks, right? So, so having a normal blood pressure doesn't matter because if you're a non-dipper, your risk is high. Having one normal blood pressure reading that you take every morning after your coffee because you
After coffee.
started to go crazy, yeah, after reading the newspaper, whatever people do, you don't take it at one point only. And so she and a lot, Dr. Carr and a lot of patients don't like wearing a blood pressure monitor 24 hours and trying to sleep with it when it's inflating and making a noise and causing all kinds of issues. And she was very annoyed after hers. She was, I knew she would never do it again. And look how promptly she solved the problem. She went and brought in a little wrist device that tracks your blood pressure all day, all night, so that we can find out if you're a non-dipper. There's no test for blood pressure other than checking your blood pressure. So what if you're like the lady I saw yesterday? I used the analogy of her sugars, but what if you have high blood pressures in parts of the day, but you don't know because you weren't checking, because you only check every morning, or you don't even check because you're lean, fit, and healthy. So she lets you use the device, and then she analyzes your data, and then that tells us, because blood pressure drives high blood pressure drives heart disease, and you must know your blood pressure because heart and brain are connected. You don't want to get a stroke either. So everything we're doing for your heart, we're actually helping your brain as well. So your evaluation, we have like a 30-40 page assessment that you fill in. We get to know every detail, even your birth and your birth weight and your whether you were breastfed, and all of that matters to your health today. How much antibiotics you've had, whatever all we ask you. It sounds crazy, but we ask you all kinds of things because it tells us how healthy or not healthy you are and your risks. And then our longevity assessment is in clinic. If you live out of town, we have patients who do come in every year for this, but if you can't come to the clinic for your longevity assessment, and we're checking things like, because science shows a lot of things can predict your healthy aging and longevity. So your muscle mass, your sit to stand test, your grip strength, all of these things are tested, and then your heart rate and how it changes. We want to know this because we can tell you about it. If you don't live in Calgary and you're outside of Calgary, we can tell you what the tests are, and you can do them on your own, or access them through your local resources. Yeah, the blood tests we do are so extensive. I mean, we're looking at hormones, we're looking at proteins, we're looking at all of that. And so you'll get your blood tests, you'll get your forms, you'll get this whole thing, and you'll get the lipid particle analysis. And then you'll get a follow-up as well. Our usual programs are $2,500, which include a lot more. This, though, is on our usual rate, it's $1,750 to get this, plus an additional amount for your lipid particle analysis. It is Heart Day today. It is Valentine's Day. It is Heart Health Month. We want you to do this. This is not because of any other reason than we want you to do it. So if you're watching this and you get the recording and you reply to us, you can have this for $999. It's very limited. We will allow only 10 people to do this. Well, we said 5 initially because that's what we had space for, but I can do some as well. So we will take you on, and this is not expensive. In a country that's used to free healthcare, I understand that, but I will tell you what free healthcare gets you. It gets me a 36-year-old into my ER having a heart attack. It gets a 42-year-old who will not see her grandchild go to college because she will not be alive after her 3rd heart attack. And the story I said I was going to tell you when I told someone that the first symptom of heart attack is death. It's a very roundabout story. Here's the thing. 23-year-old came into my emergency department on the weekend. Total alcoholic, liver enzymes deranged, seriously kidneys affected from the alcoholism, 23-year-old boy. And my son's 20 this year. you know, your son's in his 20s.
Yeah.
And his sweet mom was sitting with him, and you know, I don't judge alcoholics. I say to them, I'm here to help you, but only when you're ready is the time you're going to quit, right? Like, we know this. I'm not going to ask you to go to detox if you have no interest or plan to quit. And his mom said, you know, this is the result of him losing his dad. And I was like, oh, I mean, it's hard to lose a parent, right? I haven't lost one, you have. So, you know, I can imagine how hard that is. And then she says his dad had a heart attack and he tried to resuscitate him and it failed. And now he can't live with himself, so he drinks all day long. And he feels so bad that the CPR didn't work. And I said, I'm going to tell you something. The first symptom of heart attack is usually death. So there's almost no chance that you could have saved your father. He was dead before you could do anything. That being said, alcohol intake is a sure way to make sure you get a heart attack. It's one of the risk factors. But, you know, it makes you think, never mind that this child's life is ruined by watching his parent die. But his parent died from heart disease that we are not doing a good job educating people to prevent it, regardless of what the efforts are right now. But can you imagine being either the parent that dies and leaves your child and something like that happens, or being the person setting your kids up for that kind of heart disease and heart attack because we're not doing the right things for ourselves and our kids. We're not eating the right way. We're not understanding our risks. We're not doing advanced testing because we already know that knowing your cholesterol means nothing if more than 50% of people have heart attacks with normal cholesterol levels. So we need to do more. What we've done for you today is we've given you lots of information that you can use to improve your life and your health. But without hard, concrete data, without knowing what your inflammation markers look like, without knowing what your lipid particles size is, without knowing if you have insulin resistance, you cannot help yourself prevent a heart attack.
Yeah.
By just having information in your head. You need to know your numbers. As Dr. Kar says, always test, don't guess. So please just email us back, say you want to join the program and you want to have this heart assessment, and we will do this heart assessment for you.
Yeah. And since we have gone about 2 minutes over our time, we can take a few questions. If you have any questions, feel free to either ask in the Q&A box, or if you raise your hand, I can probably unmute you. And at this point, I'm going to stop the recording because I want to be mindful of your privacy. Okay. So the email address is, Natasha, your email address has just become longer.
Clientcare@liveyounger.ca.
Oh,
Clientcare@liveyounger.ca. We'll send it to you when we send the recording out, because everybody's
Yep.
going to get it, including those that are on it. But as Dr. Carr said, you need to be able to follow the form, get those things, and if you have any other questions, just pop an email. But at least you would know your risks. If you don't join us and get your heart assessment, then at least you will get
And once you fill out
information of
that
what your risk.
form, you'll also be added to, receiving more heart information off and on from me. And I've put in my email address as well. So I work online and most of my patients are in India. And by the way, many of you are, I know, in the Middle East. I do work with the clinic in the Middle East. And Natasha, you have patients there too. So thank you very much for joining us, and see y'all, and happy, healthy heart and brain. Bye, Natasha.
Bye, everyone.